Professor Chawla Rajeev from India, who will speak about gestational diabetes. Is mother of NCD, non-communicable disease, NCD.
Good afternoon, everyone. At the outset, I am extremely thankful to Professor Mohammed and Professor Inaz and the entire organizing committee of ASD 23 for having me here and giving me this opportunity to be part of prestigious ASD. We are lucky that we are a partner, as CMRI told in the morning also, to be presenting this as a symposium in GDM. And well, Dr. Mohammed did a wonderful job. He made a true case for when to screen and with what criteria to screen. Unfortunately, we at India, we are DIPSI people and we advocate a single test criteria of doing only a postprandial sugar 2 hours after 75 gram of glucose, irrespective of the last meal. But I think in the last, he very convincingly put it in the right way that if there is an opportunity to have a patient fasting, it is always better, because lest you miss on certain patient which you will not be able to get with postprandial 2 hours only. But if patient is coming in the afternoon in your late clinics, then maybe a 75 gram glucose criteria by DIPSI also stands good. And Dr. Shalini again talked about the GDM management, and so Professor Inas also touched upon the challenges in GDM management and the criterias. But I think what I am going to do is to take you straight through a very, very unequivocal evidence that if you have had GDM, you are having a very great risk in terms of your offspring developing NCD in the future, maybe by the time you are adolescent. So that is what I'm going to do over next 15 minutes, that GDM is actually the mother of NCD. And as Dr. Inas very rightly said, that there is a rising prevalence of type 2 diabetes, IGT in overall community. So is the rising prevalence of GDM. And truly with this idea that every 6 pregnancy, every 1 in 6 live births occur to women with some form of dysglycemia, and 85% of these are actually because of GDM. So here the concern is that GDM, what Dr. Mohammed also asked a question, that they are likely to get then subsequently to type 2 diabetes. So GDM actually represents a phase of chronic beta cell dysfunction. It is IGT outside pregnancy, what you are picking up in pregnancy as GDM. So they are obviously at a much greater risk to get converted to type 2 diabetes. So GDM must be viewed as a stage in evolution or development of type 2 diabetes. That is how we must ensure a euglycemia, which is not only going to help mother have good outcome, but also in terms of neonates and offsprings born out of hyperglycemia in pregnancy, because GDM will affect clearly both mother as well as baby. In mother, obviously there is an immediate risk in that index pregnancy of preeclampsia, increased risk of developing complication during the labor, maybe the requirement for cesarean and operative deliveries, and postpartum, of course, a recurrent GDM or developing the risk of type 2 diabetes. But in the offspring, not only there is a risk for congenital malformation, especially if GDM is coming early. We have Indian evidence telling about 15% pregnancies develop GDM as early as 10 to 12 weeks. Although AD and Caucasian studies say that you may screen at 24 to 28 weeks, but we have an evidence that 15% pregnancies, by the time they have already 12 weeks, they already have GDM. So they are the one where the risk of congenital malformation is very, very high. And of course, the neonatal complication may be prematurity, perinatal asphyxia, or respiratory distress syndrome, or all other neonatal complications are at a greater risk if you have hyperglycemia in pregnancy. And of course, what really concerns us, what I am going to allude upon, is that long-term risk of these offspring born out of GDM or hyperglycemia in pregnancy. They are the one who are likely to develop obesity, maybe type 1, but more convincingly type 2 diabetes, metabolic syndrome, hypertension, and even coronary artery risk. So lifetime risk for type 2 diabetes gets increased in women with gestational diabetes. Almost 50% of these women will develop IGT within 5 to 10 years. And overall, if you see that women with GDM will have a 10-fold increased risk of development of type 2 diabetes as compared to someone who has no GDM. not only that, if you screen these females, subsequently they are also at a greater risk for developing premature CVD. So overall 10 years risk for developing CVD or non-invasive cardiac diagnostic, need for non-invasive diagnostic procedure is going to be much higher if female had GDM. So diabetes definitely begets diabetes. Any amount of hyperglycemia in mother is going to do lot of damage, not only for immediate outcome, but in the offspring. So it is very clearly said that all those offspring born out of hyperglycemia in pregnancy, 50%, close to 50%, they are the one who tend to develop diabetes maybe in the second or in the third decade. So if we say that GDM impacts clearly two lives, for the mother, the risk of index pregnancy complication is much higher, and these females are at a greater risk for developing subsequent GDM or type 2 diabetes. But for the offspring also, this amount of maternal hyperglycemia is going to lead on to metabolic changes in the offsprings, and by the time they are adolescent, they are at a much greater risk for development of NCDs or cardiometabolic disorders. And very, very old ancient evidence, I must tell you, this is almost 300 years before Christ. Wisdom was there even at that time when science was not very great. This is Garbha Upanishad, talking about that even as the unborn baby is in the womb of a mother, these 5 things are fixed as early as during the pregnancy: the destiny of that child, the lifespan of that child, his activities, his acquisition of wealth and knowledge, and most important thing is even the time of death could also be predicted from the amount of hyperglycemia in that index pregnancy. And so is what David Barker said in 1990. He conceptualized that body susceptibility to lifestyle diseases was programmed as early as intrauterine. What we say that adult fetal onset of adult diseases, because intrauterine programming is going to be there, and that is going to lead on to permanent changes not only in the structure, physiology and the metabolism, and that is what is fetal origin of adult diseases. So when we know that a maternal metabolism in pregnancy changes physiologically to provide an uninterrupted nutrient supplies to the fetus for its growth and energy needs, it is the fetus which is getting continually being fed with the burden in an intermittently eating mother. Whether mother is eating or no, but baby is going to have a continuous amount of calories from the mother through the placenta. So that makes actually a stage for fetal insulin hypothesis. Any amount of fetal hyperglycemia will lead on to enhanced glucose sensing by the fetal pancreas. So there is going to be a hyperinsulinemia in that fetal pancreas, which will then lead on to hyperinsulin mediated growth in that offspring, and that will actually decide the insulin fetal birth weight. So Pedersen hypothesis as early as 1952 said any amount of maternal hyperglycemia will lead on to glucose hyperglycemia, which will lead on to higher input into the fetus. So there is going to be an increased secretion of the insulin with stimulation of protein, lipid and glycogen synthesis, which will then lead on to macrosomia, organomegaly, hypoglycemia, polycythemia, and of course the increased risk of respiratory distress syndrome. Even Franklin hypothesis clearly said moment there is an increased influx of all nutrients to the fetus, that will lead on to macrosomia at birth, and an immediate risk of getting hypoglycemia as early as 3 hours post delivery is there in these neonates. But long term, there is going to be a much greater risk for NCDs because of overall stimulation of the beta cells of the pancreas in the fetus during in utero stimulation. So that will increase the risk of metabolic syndrome, obesity, and subsequently coronary artery disease also. Even modified Franklin and Pedersen hypothesis said that any amount of hyperglycemia will lead on to a vicious cycle of diabetes, because if it is a male child, of course the risk of obesity is going to be much higher by the time they are adolescent. If it is a female child which is getting born as a result of hyperglycemia in pregnancy, she is the one who is likely to develop PCOD, subsequently the risk of developing GDM. So this happens to be a transgeneration transmission from that offspring which gets born out of hyperglycemia, the risk of PCOD, risk of subsequent development of GDM, and that risk getting carried to again to the fetus and to the offspring and subsequently into the adolescent as a risk for NCD. And there is a very, very strong link between maternal health and NCD burden. Not only any amount of undernutrition, but also overnutrition will increase the overall risk of developing NCDs, because it has been seen that any amount of maternal overnutrition through in utero overnutrition will lead on to epigenetic changes in genes, and these will lead on to an altered physiology leading on to insulin resistance and beta cell dysfunction. Subsequent risk of diabetes and CVD will be much high. Any amount of maternal undernutrition again will lead on to hypoxia, metabolic changes, so that again leads on to poor fetal programming. So overall risk of NCDs in these offerings will be much higher. So intrauterine growth restriction to the fetus also is going to lead on to changes not only into the endocrine axis, into the muscles, into the liver, into the pancreas, into the cardiovascular system, also into the cognitive function, which will happen by the time these offsprings are becoming adolescent. Not only that, the consequences of gestational diabetes are clearly seen through hypothalamic dysfunction, but also in various other organs, even into the respiratory system. These children are likely to develop COPDs and asthma. So GDM may play a very, very crucial role in increasing prevalence of diabetes and obesity, because origin of all these cardiometabolic diseases gets set in utero. So it is actually a vicious cycle of diabetes and obesity. Any amount of maternal obesity and hyperglycemia will lead on to fetal overnutrition, which will increase the risk of adolescent obesity and early onset of type 2 diabetes and NCD. And this is what I said, not only pancreatic overstimulation will lead on to endothelial dysfunction and chronic changes and a greater risk of metabolic syndrome, but also the risk of developing respiratory diseases in this offspring born out of hyperglycemia and pregnancy is very, very high. So GDM may play a crucial role in increasing the prevalence of diabetes and obesity. When these days we are talking of prevention of NCD, we must focus on these females, those who are having hyperglycemia. And that is why we say that there has to be a universal screening and prompt management of all pregnant women for any amount of glucose intolerance. We are not talking of only GDM, we are talking of EGI, which is a early glucose intolerance in pregnancy, which is something like when your sugar is between 120 to 142 hours, it is not exceeding 140 to get the diagnosis GDM, but even if it is between 120 to 140, these females at least should be on lifestyle modification to reduce that persistent hyperglycemia. And it has to be a public health priority, because all these offspring will ultimately develop NCD. So when we talk of prevention of diabetes, it must start, when we are talking of prevention of NCD, it must start during intrauterine, not only in form of screening, in form of better management. And as Dr. Shalini very rightly said, if we can ensure a amount of normoglycemia when fetus will not realize that my mother has hyperglycemia, probably we may check the progression of NCDs in these females. So it is very well said that a female gender is probably key to diabetes prevention, and any amount of hyperglycemia or may lead on to either a low birth weight or a macrosomia will ultimately reflect in the form of development of chronic diseases in the adulthood. So a maternal health must be viewed as a link to NCD epidemic, and GDM must be screened as early as 12 weeks, what all guidelines say. These days we are talking about primordial prevention, and Mohammed, to share with you, through Director General Health Services, we have enrolled 8 centers across the country. We are already having 1 center in Delhi, where we are talking of a screening as early as 8 to 9 weeks to make sure that capillary sugar 2 hours is not more than 110. We are not talking of 120 or 140. It is said that if capillary sugar at 2 hours is more than 110, maybe it is 112 or 115, that will lead on to a fetal glucose steal phenomena into the mother. So if you check the sugar at 13 weeks, by then, because of beta cell stimulation of the pancreas, which may handle sugar for the mother, sugar may come down to less than 120. So there is an opportunity to miss those females who might have actually hyperglycemia anything between 110 to 120. So we are talking of a primordial prevention by early screening. So to conclude, GDM must be viewed as a window of opportunity because pregnancy offers a window of opportunity to provide maternal care services. We must look into reduction of traditional maternal and perinatal morbidity and mortality. This must be addressed too. And we must address intergenerational prevention of NCD by screening these females early and by managing them well so that we can check the progression of NCD. So to conclude, we as clinicians are afforded with this rare opportunity to alter the natural course of disease and change the future health of not only that woman, but also offspring getting born out of that, and probably we may do wonders in form of reduction in NCD if we can focus on these fetus for the future. Professor V.C. Shai, who is a professor, who is a father of gestational diabetes in India, a living legend, still at the age of 85, he's the one who has given the concept of primordial prevention at this age, and we are all his followers. He has been our patron in DIPSI, and he's the one that we must focus on fetus for the future if we want to change the course of NCDs in these patients. Thank you very much. If you have